Hello friends, so today I'll be talking on this topic mucolytics in ICU. So this was an old topic which I had deliberated with my team some time ago. So the reason I thought I'll revisit is because in COVID situation there have been some instances where mucolytics is being used in the wards and maybe by other doctors. So it is just important to revisit this topic whether these mucolytics are of any benefit. So this talk may not be very specific to COVID, but it is in general about the extensive usage of mucolytics in ICU. So this was one study which I looked into, airway response, and I have to say, when you look for evidence for mucolytics, they're all very old studies. There is no new studies looking at whether there is any benefit with mucolytics, because it appears to me when you review the literature, it seems to have been done and dusted that it may not hold much value, at least in ICU. So this was a German study, airway response to inhaled hypertonic saline in patients with moderate to severe COPD. So I remember when I was doing my medicine postgraduate in St. John's, we used to give steam inhalation as a norm in COPD or any respiratory issues. So it's important to note whether it's of any benefit. Okay, so the hypothesis is the normal saline nebulization that one gives as 0.9% or 3%. The hypothesis is it facilitates, it humidifies and facilitates mucus clearance and stimulates cough and reduces the viscoelasticity of the mucus, and it reduces the sputum spinning. So this is the hypothesis that it helps in the clearance of mucus by improving the mucociliary clearance and liquefying the sputum and facilitating its expectoration. And it is also shown that the reduction of the PFT, pulmonary function test, that happened is sort of mast cell mediated, and that also to some extent would be mitigated by this saline. So this particular study was done in 20 patients. So the age group was 48 to 70 years, and all these patients had COPD with FEV1 of 29 to 58, which means they had a bad COPD where FEV1 was fairly low, which was only about 29 to 58% of predictor, which means they took all symptomatic proven COPD patients. So what were the results they found? So they had 20 patients and they had one group which had salbutamol, where they gave 200 microgram as a metered dose inhaler. The second group had saline salbutamol with 0.9% normal saline. They gave it 4 times for 5 minutes. Then the third group had 3%. So they took 0.9%, 3%, and they compared with salbutamol. So if you see, so salbutamol was a common factor. The FEV1 should improve, right? So here, in fact, it came down when they in a group which had 0.9% saline and 3% saline, and that was statistically significant. They looked at inspiratory capacity, that should increase with any nebulization. That would be your hypothesis that it improves. Here again, it came down when they gave in the saline group or in the hypertonic saline group, and that was also statistically significant. Okay, so again that's the, so then they looked at intrathoracic gas volume. See, in COPD there is a lot of gas inside the lung, so your whole attempt is to have a good expiration so that enough gas is expelled. So here you see intrathoracic gas volume came down with salbutamol, and with saline group and hypertonic saline, in fact the intrathoracic gas volume had increased. So which means to say it didn't confer any benefit even with the use of these 3% saline, because your ITGV you would expect it to come down because you don't want too much gas trapping, which typically happens in COPD. And they looked at airway resistance. So airway resistance, obviously your expectation or hypothesis is it should come down with the use of these nebulizer. And you saw with salbutamol it came down, but when you added normal saline, in fact it went up. Your static resistance, airway resistance, sort of it did increase with use of this. And they looked at the visual analog score, whether of the comfort factor. So in fact the comfort factor became negative when they gave saline. So the whole understanding of this is the saline, especially see this was more severe in hypertonic saline. So it's an irritant, and it has been shown, and any mucolytics you read or talk about, always there is a disclaimer or there is a corollary which says it has to be administered always with bronchodilator. So what does that mean? It means they may be irritant at best, and this saline can induce bronchospasm. And you would see in the subsequent slides some of the other mucolytics that you use. Some of them have ability to induce bronchospasm. So it appears to us that maybe the bronchospasm was sort of tended to be getting worse with the use of these hypertonic saline, because your visual analog score indicated they were not very comfortable, your airway resistance increased, and your gas volumes increased, which you would have expected it to reduce, and your inspiratory capacity also came down. So, and they also examined the histamine level in the sputum, and they saw there was increased histamine release in 0.9%, and the histamine release was much more in the 3% saline group, which goes on to show there is more of mast cell degranulation that happens with saline. So this study clearly shows that saline definitely may be more harmful by inducing histamine release, and it didn't offer absolutely no benefit in especially the COPD patients. And these are all the values between salbutamol 0.9% saline and 3%. So they looked at various pulmonary function, and there was no benefit. If at all, things gotten worse. Okay. So that was the key findings of this study. And this was the graphical representation of 0.9% saline group and 3% saline group on the change in the FEV1. So the conclusions is aerosol saline nebulization was useless, and there is no evidence. If at all, it causes more harm. Okay. So that's about the saline. If you're talking about saline, if it has any benefit, then we'll go into mucolytics. So I see many a times some of our trainee doctors also writing this mucolytics for some of the patients with. There are various mucolytics. So ambroxol, bromhexine, guaifenesin, ipecac, ammonium. So these are all the components of various mucolytic cough syrups that are available. So again, the hypothesis is you use mucolytics, it increases sputum production, and it enhances your mucociliary clearance, and it liquefies the sputum and reduces the viscosity so that expectoration happens effectively. So these are the two studies I have indicated down. Not worthwhile going to the details of the study, but none of the studies have shown it improves pulmonary function tests. There was no effect even on cough frequency. There was no effect on emotional well-being, and there was no effect on content or weight of the sputum also. So there was, at least when you look at core evidence, there was no evidence with improvement in any of these variables. So the conclusions is mucolytics also are useless, at least in ICU, and there's no evidence, and it could only add on to our ICU cost. Okay. So this is, we did a small audit when some of our trainee doctors or our physician friends maybe in the wards were using a lot of this mucolytics as a standard for all these respiratory cases. So the mucolytic syrup is usually given as a dose of 15 ml TID. So 100 ml bottle will cost around 45 rupees, which is not much, and one bottle will last only for 2.2 to 2.5 days if you give it at 15 ml TID. So it comes to around 145 rupees for 7 days. Okay. So sounds negligible, but definitely adds on to the cumulative ICU cost, and I'll show you how it will add on to the ICU cost. And there's no benefit, if at all. It may, at least the saline we know it can cause harm. So mucolytics may increase your sugar levels maybe, because they're all very sweet in nature. Okay. Okay. Now this is another favorite which many of my trainees tend to subscribe to. They give us NAC, N-acetylcysteine nebulization or tablets. So again, the hypothesis is this is the chemical structure. It liquefies sputum, and DNA also is what is proposed. And the onset of action of acetylcysteine is 1 minute. It acts pretty quickly when you give it as a nebulization, and the peak action is 5 to 10 minutes. And see, this is the important thing. See, even when you read the literature, it is mentioned that acetylcysteine should be given with your other bronchodilators. It cannot be given by itself because it can cause bronchospasm. See, recommended to be used along with bronchodilators, and it has shown poor penetration into the bowel fluid. And this was a big study that was done, European bronchus trial. So this was a big study. 523 patients were recruited across 50 centers, and this study was done over 3 years period. And it was a randomized controlled trial. So this was the bronchus trial. So this was the results. So they had 523 patients, 50 centers. They looked at yearly reduction of FEV1. So they found that the reduction was more in NAC, which is not good compared to placebo, although there was no statistically significance between placebo group and NAC group. And exacerbations, they looked at the respiratory exacerbations because this was done obviously in a COPD patients, and it remained the same. So the use of NAC had not shown any benefit with reducing the exacerbations, and that was also statistically not significant. So there was no difference between placebo and the NAC. So this was the Kaplan-Meier curves between the NAC and the placebo. As you see, there's not much difference. Okay. So again goes on to show that it may not hold much value. And this was another study. So basically there was no effect on duration of antibiotic use. There was no effect on length of stay. There was no effect on mucus clearance and no effect on mucociliary clearance. So NAC also sees the same fate of your mucolytic, that it did not have any benefit with regards to mucus clearance or in relation to any of the COPD endpoints. So conclusions the authors made was the N-acetylcysteine is not recommended in view of minimal therapeutic benefits, cost and potential side effects. Potential side effects is it can induce bronchospasm. Okay, so that's the side effects. So again we reviewed the usage of N-acetylcysteine in our hospital. Cary is our hospital, Columbia Asia Referral Hospital, Yeshwantpur. So some of the physicians or doctors in the ward or even some of my trainees write this Mucomix tablet 600 mg TID, which comes to around 48 rupees. And it comes as pack of 20, it costs around 320 rupees. So one tablet costs around 16 rupees. So it comes to around 336 rupees for 1 week. So you should add this cost on to your mucolytic syrups also, which some of them write. And if you give nebulization, it comes 6th hourly. When you give it, nebulization is a little more expensive. It comes to around 520 rupees. So if you use 5 into 5 ml, it comes to around 650, and 1 into 5 ml is around 130. So the cumulative cost for 1 week, it will come to around 3640 for 1 week if you are using Mucomix or N-acetylcysteine as a nebulization, which I see even now and then it gets written on the chart. So total it comes to around 3,976 per week for no benefit and possible harm. So this is the evidence for N-acetylcysteine. Then some of the pulmonology people have seen, they write this Mistabron, which is sodium 2 mercapto ethane sulfonate. So that is the component of Mistabron. So it is shown that Mistabron in fact increases the respiratory airway resistance. And again, you are seeing time and again, whichever mucolytics you see, NAC or Saline or Mistabron, there is always a underpinning that it has to be used with bronchodilators. Why? Because they can induce sort of bronchospasm, increase airway resistance, increase histamine release, which we saw with the use of saline as well. So again here Mistabron, they say it should be used with bronchodilator. And the way Mistabron made its inroads was this particular paper which showed beneficial effect in cystic fibrosis. And as I said, all these papers are very old, because any literature you look for this mucolytics come from very old papers, around 10 to at least 10 to 15 years back papers, no more than 20 years back papers. So following this particular paper, this was an editorial that came in Europe. Mistabron appeared to enhance mucociliary clearance in patients with chronic bronchitis, although the results did not quite reach statistical significance, a feature of so many studies of mucolytics. Which means to say, as a reply to this particular paper, which increased the enthusiasm of people considering to use Mistabron, there was an editorial which said that it did not really reach statistical significance, and we aren't sure at that point of time. So this was one study which came after that, which was a very horrid study. It was not a controlled study. It was a very industry-sponsored trial where they did in 80 post-op thoracic patients, and they have given Mistabron as a bronchial lavage, 15 to 20 ml or 10 to 20 times per day. See, I mean, ethically, you would wonder how this could be cleared by giving bronchial lavage 10 to 20 times per day of Mistabron. And here they have done bronchial instillation of 15 to 20 ml, 3 to 5 times per day. And then they gave nebulizations, continuous 4 to 5 amps. And they have looked at very subjective variables of the sputum. So it was not a controlled arm. So they have just made their own observations and said it has been beneficial. So this is not a any sort of a good study to look at, because there is no control arm, and possibly it appeared to be a pharma driven study where authors have just made their observations of how it has benefited with the consistency and clearance of the sputum. So, how about our Mr. Brand Mesna use? So, initially, when I started working, so there was a use of this from our pulmonology friends, and Mesna nebulization or Mr. Braun is given for 3 times a day. One ampule costs around 30 rupees. It comes to around 630 rupees for 1 week. So, if used as per the study, continuous NEPs 5 to 10 ml per hour, it comes to around 3600 per day. Uh, because if you see the previous study, they have used extraordinary amount of dosage. If you see a bronchial instillation, and if you see the nebulization also, they have given continuous nebulization 4 to 5 ampules in 24 hours. So, so basically to summarize the whole subject, so if you add in that mucolytic syrup along with Mr. Brown, along with N-acetylcysteine, the cumulative non-useful cost incurred to the patient in our hospital per week would be 4,749, which may not appear too big in the whole scheme of things, but we should be aware of its absolutely non-benefit, and if at all it induces bronchospasm in some of the patients, and maybe causing some harm with histamine release. So in that way, the scientific community is looking at core evidence, there's absolutely no evidence for use of any of these drugs in ICU setting. So thank you very much. I end my talk with this quote. Sometimes people don't notice the things you do for them until you stop doing them. Thank you all.